Assalamu alaikum. Let's talk about a new journey. In the land of medicine, there are plenty of wonderful topics, which is very complicated to diagnose and very interesting to treat. One of them is sarcoidosis. Okay, we know that sarcoidosis is an idiopathic. It's an idiopathic condition. It's an idiopathic condition featuring granuloma, featuring granulomatous inflammation. It causes, it features granulomatous inflammation that involves multiple organs, very high health. It involves multiple organ system with prominent involvement of the lungs and the lymphatic. And in the sarcoidosis, there is prominent involvement of the lungs and the lymphatic. If we look at the clinical manifestations of a patient with the sarcoidosis, in short, in the lung, you may get primary granuloma. In the eye, there may be ocular inflammation, uveitis. Neurological findings may be found. Neurosarcoidosis is called, and there may be cervical thoracic lymphadenopathy, there may be cardiomyopathy, there may be splenomegaly, there may be hepatomegaly, there may be skin lesion, there may be arthritis. Arthritis, there may be skin lesion, splenomegaly, hepatomegaly, cardiomyopathy, cervical thoracic lymphadenopathy, ocular inflammation, neurologic lesions, primary granuloma may be found. Sarcoidosis clusters among first-degree relatives, especially among individuals African, Scandinavian, supporting a genetic component. Several human leukocyte antigen alleles HLA DRB1 variants are common in patients with sarcoidosis when bound to speculative antigen beryllium. These HLA encoded major histocompatibility complex appear to be strongly engaged to T helper cell response and sustained coactivation of the CD helper T lymphocyte and macrophage form compact immune system known as non-caseating granuloma. Okay, clinical manifestation. If you look at the clinical manifestation, sarcoidosis affects multiple organs. It can involve pulmonary. In pulmonary involvement, it can cause BHL, bilateral hilar lymphadenopathy. There may be interstitial infiltrate. There may be interstitial infiltrate. There may be interstitial infiltrate. In cutaneous, there may be papilla nodular and plaque-like lesion. There may be EN, erythema nodosum. In ophthalmologic finding, we may found anterior uveitis, iridocyclitis or iritis, posterior uveitis. In ophthalmitis, there may be anterior uveitis, there may be posterior uveitis, and there may be keratoconjunctivitis sicca, there may be keratoconjunctivitis sicca. If you look at the MSK finding, musculoskeletal finding, there may be acute polyarthritis, there may be acute polyarthritis and chronic arthritis. there may be acute polyarthritis, there may be chronic arthritis, there may be acute polyarthritis, there may be chronic arthritis. In cerebrovascular disease, there may be AV block. In cerebrovascular disease, there may be AV block or dilated or restrictive cardiomyopathy, dilated or restrictive cardiomyopathy. There may be dilated or restricted cardiomyopathy. And in CNS, on CNS, there may be facial nerve palsy, there may be facial nerve palsy, there may be CDI, central diabetes insipidus. So these are the manifestation may be found, and there is another syndrome called Lofgren syndrome. Lofgren syndrome, erythema nodosum, bilateral hilar lymphadenopathy, migratory polyarthalgia, and there may be fever. There may be fever. These are the features can be found in uh, overall sarcoidosis. These are the major main clinical manifestation we may found in sarcoidosis. Okay, pulmonary sarcoidosis, 90% of the patient sarcoidosis has lung involvement. If we do chest imaging, there may be mediastinal, mediastinal and bilateral hilar adenopathy. There may be mediastinal and bilateral hilar adenopathy, and there may be varying degrees. There may be mm, and there may be varying degrees of things. There may be varying degrees of things. If we go through the chest imaging usually show mediastinal and bilateral hilar lymphadenopathy and varying degrees of parenchymal infiltrate reticular opacities, nodules, consolidation, ground glass opacities, and there is pulmonary sarcoidosis staging regarding radiographic appearance. There are four types. One is bilateral hilar lymphadenopathy, often with right paratracheal lymph node, paratracheal node enlargement, and two, bilateral hilar bilateral hilar adenopathy with reticular opacity. There may be reticular opacities. Upper is more than the lower. And three, there is reticular opacities. There is reticular opacities, and mostly in the upper lobe, reticular opacity and shrinking hilar nodes. And four is reticular opacity and volume loss. Reticular opacity and volume loss. Reticular opacity and volume loss. These are the pulmonary sarcoidosis staging. Extrapulmonary sarcoidosis, there may be cardiac involvement. We know that there may be cardiac involvement. There may be conduction system disease, AV block, and there may be bundle branch block. There may be cardiomyopathy. If we look at the cutaneous manifestation, there will be lupus panio and erythema nodosum. Lupus panio reddish violaceous induration affecting the nerves and the interstitium. Lupus pernio, slowly progressive in duration, slowly progressive in duration in the nears and the midline phase, often resistance to treatment and causing disfigurement. And erythema nodosum, there is paniculitis, immune complex deposition and inflammation of the subcutaneous band with red tender macules, usually affecting the shins and the foreleg. And there may be ophthalmologic finding anterior and posterior uveitis. Anterior is painful, posterior is painless, visual loss. Then may be um, keratoconjunctivitis sicca. And in here, there may be seventh nerve palsy. Seventh nerve palsy can be bilateral seven nerve palsy. There may be diabetes insipidus. There may be diabetes insipidus. There will be leptomeningeal spread and chronic aseptic meningitis. On endocrine, there may be hypercalcemia. On endocrine, there may be hypercalcemia. Acute sarcoidosis, there may be Lofgren syndrome. There may be Harford syndrome. Lofgren syndrome is fever, polyarthralgia, especially medium-sized joints such as ankles and the knee, and erythema nodosum highlighted with the Harford syndrome, fever, anterior uveitis, bilateral parotitis, and cranial seven nerve palsy fever, anterior uveitis, fever, anterior uveitis, bilateral parotitis, fever, anterior uveitis, bilateral parotitis, and cranial seven nerve palsy. A biopsy, if we want to diagnose, if we want to diagnose biopsy of demonstrating non-caseating granuloma is generally necessary to prove sarcoidosis, but biopsy can be avoided for certain pathognomonic presentation. There may be asymptomatic hilar lymphadenopathy, there may be acute sarcoidosis, there may be lupus imaging suspected cardiac sarcoidosis. There may be cardiac sarcoidosis also. Hmm. If we look at the differential of this sarcoidosis, there may be other granulomatous lung disease, There may be hypersensitivity pneumonitis. There may be silicosis. There may be granulomatous systemic disease, infection, mycobacterium TB, mycobacterium avium, fungal nocardia. There may be malignancy, primary immune deficiency, ANCA, small vessel vasculitis. Non-granulomatous is idiopathic pulmonary fibrosis, idiopathic pulmonary fibrosis. If we look at the treatment, sarcoidosis, if we look at the sarcoidosis, um, if we look at the sarcoidosis, additional therapies, we know that most important drug for sarcoidosis is a steroid, and steroid is the number one drug. Treatment involves systemic steroid usually administered for several months or often up to a year. Refractory disease requires additional immune suppression ranging anti-metabolized methotrexate, mycophenolate, mofetil, biologics, anti-TNF alpha inhibitor, TNF alpha inhibitor, monoclonal antibody, infliximab. Biologics is anti-TNF alpha inhibitor or B cell depleter or rituximab. Milder disease. So most important thing we need to remember that steroid is the number one drug for ear and it should be taken often up to a year. And refractory disease, requires immunosuppressive ranging from anti-metabolites, methotrexate, mycophenolate mofetil to the biologic acid anti-TNF-alpha inhibitor, and non-organ threatening erythema nodosum general polyarthalgia. Prognosis: most patients with sarcoidosis have a favorable outcome. Approximately two-thirds of the patient experience spontaneous remission and mild pain. One-third of the patient chronic progressive disease course that leads to irreversible organ damage like pulmonary fibrosis, heart failure with increased mortality. And important thing, if there is lung involvement, abnormal pulmonary function test dyspnea, you should give we should give uh, abnormal pulmonary function test dyspnea, indication for systemic corticosteroid, skin disfiguring plaques and nodules, lupus pernio, go for systemic steroid, musculoskeletal arthritis, myositis, myopathy, go for systemic corticosteroid, and indication additional is arthalgia. Infiltrative cardiomyopathy, conduction system disease. In this case, we can give systemic corticosteroid, and indication for additional therapy dysrhythmia is ICD and pacemaker. CNS neuropathy, facial nerve 7 pulse, encephalopathy, go for systemic corticosteroid. Hypopituitarism, if there is hypopituitarism, go for hormone replacement. In uveitis, go for steroid, and other like symptomatic hypocalcemia, we should give steroid. Any organ threatening disease unresponsive, any organ threatening disease unresponsive to corticosteroid, methotrexate, anti-TNF alpha, TNF alpha, infliximab, adalimumab, golimumab, etanercept. So this is all about sarcoidosis. Hope you enjoyed.